Good afternoon, ladies, and welcome to the Lexington Alumnae chapter of Delta Sigma Theta's Am I My Sister's Keeper, a Women's Heart Health Summit. We're very glad that you have joined us today in this day and age when we are all, as we're all here today, trying to receive some type of education, a tip, or a bit of information to share with our loved ones, our communities, and just to learn for ourselves. We wanted to thank you, first of all, for sharing your afternoon with us, but also in this day and age when we are embedded in this superwoman mentality, we have to learn to take care of ourselves. And there's great programming here where there will be some stories shared for you concerning survivors, but also information that you can take to heart, pun intended, so that we all reach a better physical understanding. We know that we have the ability to do great things, but if our physical health is not intact, we can't carry on the ideals and the movement of our community. We can't move forward. And we know that as women, we generally have carried the burden, the woes, and the movement of society and our communities on our shoulders. And so we just want to welcome you to this program. We hope that you will take this information to heart. We hope that you will take this information back and share it with others. And, you know, we always say when we know better, we do better. So hopefully this information will put you on a different path to taking care of yourself first, because we know that as we carry the burdens and shoulder the weight of the world, when we go down, so does the world. So we just want to say welcome, welcome, welcome. We're going to start with an invocation by Dr. Bonnie Mitchell-Clark.
Let us bow. Oh God, our Father, we thank you for this day, and we thank you for your many blessings. We pray that you will now be with us as we present this event, sharing information by many individuals. We thank you for allowing them to learn those things that are so important to our lives and good health. We thank you for the opportunity to share that information. We pray that you will bless those who present to recall all of their facts accurately. And we thank you too, Lord, and ask you to bless those who hear these facts, and that they will be motivated to apply as much as they can to their individual lives. Now be with us as we embark on the presentation. In Jesus' name we pray and give thanks. Amen.
Amen. Thank you, Dr. Bonnie Mitchell-Clark. Now, I would like to present to you the facilitator for this afternoon. Her name is Michonne Jonikin. She's a member of the Lexington Alumnae chapter of Delta Sigma Theta Sorority Incorporated. She's a native of Lexington, Kentucky, and she is a pediatric cardiologist. She's the founder and CEO of Hearts Matter LLC, which is based here in Lexington. Dr. Jonikin is a graduate of Tuskegee University with a master's in epidemiology from Stanford University. She graduated from Howard University College of Medicine. And Dr. Jonikin completed medical training in pediatrics at Children's National Medical Center and in cardiology from Washington University in St. Louis, Boston Children's Hospital. Dr. Jonikin's clinical interests include emergency cardiac care and international health, completing field work in several African countries, Rio de Janeiro, and the Dominican Republic. Dr. Jonikin is a legacy and a proud member of Delta Sigma Theta, and an active member, I will say, as well. and she enjoys aerobic boxing, distance running, and women's Christian studies. Dr. Jonathan is not only a physician, but a patient, and she is currently a 6-year breast cancer survivor. So at this time, I'd like to welcome Dr. Jonathan, and I will turn the program over to her. Thank you.
Thank you, SOAR President, and thank all of you for taking the time out to come and share with us on this Heart Health Summit today, this Saturday, February the 19th. I wanted to just introduce to you what the order of the program is going to be for this afternoon. We have several lovely, enchanting, and beautiful speakers that will be speaking with you this afternoon. We're going to start with the ladies of the Mu Epsilon chapter, Delta Sigma Theta, here in Lexington at the University of Kentucky. We have several renowned clinicians that will be speaking this afternoon and sharing some clinical knowledge with us, as well as some very phenomenal survivors who are going to be sharing their stories with us. We're also going to be joined by the American Heart Association Kentucky State Advocacy Team, and they're going to be discussing with us some of the legislation that's currently out there regarding heart health. And lastly, we're going to have a discussion panel with our clinicians and survivors just to discuss some of the common topics that have been presented before us. Just a few virtual event reminders. I think that we are all very much more Zoom savvy than we were 2 years ago, for sure, but we still always have some kinks. I know I do. So we're just going to make this, just put this out there. Please remain muted while as part of the audience. Please ensure that your name is actually your name on Zoom and it's not, your cousin's name because you got the link at the last minute. Please complete our pre-event survey. We have a pre-event survey because we want to measure the impact of this event. You can find that pre-event survey at a very short and simple URL. That's www.lac123.org. Kind of like ABC 123, no, LAC, Lexington Alumni Chapter 123.org. Our chat submissions are going to be monitored by our technology committee, and we will be monitoring those. Please remain respectful of others in the audience. And last but certainly not least, please sit back, enjoy, educate, empower, and elevate. We are now starting with our first in our line of beautiful presenters today. These are the ladies of the Mu Epsilon chapter of Delta Sigma Theta Sorority Incorporated. Joining us today is going to be Ms. Jada Taylor. She's a native of Louisville, Kentucky, with a major in biology and a minor in gender women's studies. Also, we have Ms. Deja Robinson, who's a native of Decatur, Georgia. She's majoring in equine, and we have Ms. Carolyn Webster, who's also a native of Louisville, Kentucky, and is majoring in psychology with a minor in communication. So we have some very bright and intelligent young ladies, and I am going to let you ladies take it over for us and just tell me when you want to advance your screen.
Okay, thank you so much for that introduction. We will be discussing women's heart health facts today. My name is Carolyn Webster, and you can go ahead to the next slide for me, please. Thank you. So first we'll discuss the global impact. As of right now, the global risk of stroke and heart disease right now is up to a relative increase of 8.9%. It is something that really impacts so many across the nation for many, due to many reasons. So there are more than 40% of non-Hispanic Blacks who have high blood pressure, which is more severe in Black people than it is in white people, and it typically develops earlier in our lives as well. This could be related to stress, diet, so many reasons. Currently, more than 1 in 3 adults are actually living with some sort of cardiovascular disease. And additionally, strokes, which we hear of so often, are the second leading cause of death in the world, accounting for about 11.3% of total deaths worldwide. So that's why it is so important for us to do all that we can to decrease that risk. get active. If you aren't already, stay active. Just, choose healthier options in your diet whenever you can, and just also manage your stress as best as you can. And next slide, please.
So as far as national impact, heart disease costs the United States approximately $363 billion per year. And these costs include healthcare services, medicine, and also cost productivity loss due to death. So heart disease is the number one cause of death. And in 2019, it accounted for 874,613 deaths. So on average, a person dies every 36 seconds. So you can see that it's very prevalent within the United States. So heart disease is the leading cause of death for men, women, and people of most racial and ethnic groups within the United States. And this can be linked to a lot of the factors that were just mentioned. But typically neighborhoods with lower income or higher proportions of race or ethnic minorities are more likely to encounter health disparities or lack of healthcare access, also lack of access to healthier food options. So food deserts are very prevalent within minority communities, as well as lack of green spaces or facilities that promote physical activity. So all of these contribute to the higher rates of minority groups being affected. And you can go to the next slide, please.
Good afternoon, everyone. So now we're going to get into the impact of women of color. So 49% of African-American women ages 20 and older have heart disease. Only 1 in 5 African-American women believe she is personally at risk for heart disease. And only 58% of African-American women are aware of the signs and symptoms of a heart attack. Only 36% of African-American women know that heart disease is their greatest health risk. And lastly, African-American women have almost 2 times the risk of a stroke than Caucasians and are more likely to die at an earlier age when compared to women of other ethnicities.
And these are just some key resources. So the American Heart Association, Go Red for Women, as well as the CDC provides various preventative measures and more information on symptoms or facts on when you should get checked. So thank you all for having us.
Thank you, Soros, for taking the time out of your busy schedule, because we know that undergraduate work is not easy, and we know that you also have a full day of service coming up today. So we very much appreciate you coming, and we're looking forward to all of our works going forward in the near future. All right, so as we look at the statistics and the facts that the sorors at Mu Epsilon chapter just shared with us, I think that we can really understand the impact, the global impact of heart disease in this country and in our community in particular. And so when we talk about heart health with regards to women and heart health, I think it's really, you can't tell that story without talking about the overall fortitude that it takes to be a survivor of cardiovascular health. And right now I want to share with you, we want to introduce to some and to kind of introduce others. This is our soror, Laura Lean Jordan, who's a member of Delta Sigma Theta Minneapolis St. Paul Alumnae chapter. And let's just take a listen at her story as she shares it with us. Every 80 seconds, a woman dies of heart disease. Every 80 seconds. A mother. A sister. A friend. Heart disease is taking our futures, our potentials. But what if the hands of heart disease were stopped, just in the nick of time?
He's like, she was right. It had ruptured. She was starting to go into congestive heart failure. He's like, we got in there in the nick of time. I am originally from Springfield, Illinois, born and raised. I've been in Minnesota for 22 years now. I am an adventure seeker, thrill seeker. I have a loud side and I have a very quiet side. I am a choir director. I direct the gospel choir at a Catholic church. So I come from a long line of ministers. I am the middle of 3 girls. I am a legacy. My mother is a Delta, and then the oldest sister cousin is a Delta.
Notably, it was changes in Miss Jordan's active lifestyle that first suggested she had heart disease.
So I've always done some type of activity. It was a time where I was doing some type of activity that I would normally be able to do. And all of a sudden, I can see my rhythm go up to, normally active would be like 110, 115. It'll be 150, 160. That would be my heart rate. And I'm like, oh my God, that's high. There were times where I'd just go around the block or just decided to go for a walk at home. And I just feel out of breath, like I couldn't walk to the end of the driveway.
Fatigue, exercise intolerance, and shortness of breath may be signs the heart is not pumping effectively.
When I went to my regular physician, she would start asking follow-up questions. When I went to urgent care or the hospital, they would just chalk it up to, oh, you're stressed. And originally, they had me do a stress test. And then they're like, oh, you have a lot of stress in your life. We're going to do a psychological. We need you to see a therapist.
Research has shown physicians to be significantly less certain of heart disease symptoms in women. Women aged 45 to 64 were twice more likely to be misdiagnosed with a mental health condition. But Miss Jordan's symptoms were not all in her head.
My murmur was changing every time I went in. Sometimes she could barely hear it. Sometimes she could really hear it without even putting the stethoscope on my heart. She could just put it right here and she could hear it.
Miss Jordan also had different blood pressures in her left and right arm. A greater than 15-point blood pressure difference between the left and right arm may indicate cardiovascular disease.
So she knew something wasn't right. And so she started ordering all these tests. And it was really actually the last test. And I wasn't going to do the test. And she's like, just humor me. Do this last test. They're going to take a scope down your throat to see the backside of your heart.
It's not uncommon for multiple imaging tests to be performed before diagnosing a heart condition. Miss Jordan's last test, a transesophageal echocardiogram, showed a sinus of Valsalva aneurysm, an abnormal stretching of the tissue connecting the heart to the aorta. Found in less than 1% of the population, a ruptured sinus of Valsalva aneurysm can be life-threatening.
And he drew a picture of the heart, the cardiac surgeon, and he said, oh, so this is the problem. You have an aneurysm. He said about the size of a quarter, shaped like a strawberry, off your aorta, right above your valve. And I said, okay, well, how you fix it? And he said, well, we have to go in. And I said, excuse me? He said, we have to go in, open heart surgery, put you on a bypass machine, take your heart out. We'll be able to use some of your heart tissue, plant that spot, put the tissue over it, and you should be good. And immediately I turned to my mom and I said, I don't want to die.
Miss Jordan's surgery required her heart to be stopped. She would have to be placed on cardiopulmonary bypass or a heart-lung machine for the procedure.
On the 5th, I'm sitting at work and all of a sudden I just didn't feel well. And a coworker, she said, your lips are blue. You don't look well. So another soror came and picked me up. We were driving to the hospital and I'm just like, well, do you feel okay? I said, yeah, I feel better now. I don't know if I want to go to the hospital or just go home. She's like, no, we're taking you to the hospital. I got there. They started hooking me up to machines and everything calmed down. They were going to send me home. But my friends were adamant, like, no, don't send her home. They started running the test. And it was when they did the aortogram and angiogram that they realized that it was starting to leak. And the times that I didn't feel well, it was leaking. and it was mixing oxygenated and non-oxygenated blood. And that's what was causing the blood pressure in two different arms, the shortness of breath, all of that. After the surgery, the doctor asked my mom, she said, had she been complaining about she wasn't feeling well? Mom's like, yeah, all night long, the bells were going off. She just wasn't feeling well. He's like, she was right. It had ruptured. She was starting to go into congestive heart failure. He's like, we got in there in the nick of time. And he's like, she was one that listens to her body, and she knew something was going wrong.
Ms. Jordan did know her body. She now serves as an advocate for the American Heart Association, encouraging others to advocate for their health. Knowing her life was spared in the nick of time, Ms. Jordan now lives out the meaning of her favorite song.
I give myself away.
We started singing Give Myself Away.
I give myself away. So you
Through that song, I realized that words, my life is not my own, to you I belong. I realized that it's not about me. You know, he put me in places and put me with people where I'm supposed to be, and that's my life path. And through putting me in places and people, you know, things will come to fruition that I may not know the reason why, but it will happen.
so you can use me. I give myself away. What would happen if a generation embraced this? Come on, tell them, here I am. Here I am. Here I stand. Lord, my life is in your hands.
So we want to certainly thank Ms. Jordan for sharing her story with us. We look forward also to having Ms. Jordan join us as part of the panel so that we can get her unique perspective on being a cardiac disease survivor. All right, so I am very proud to introduce Dr. Michelle Wallace to each and every one of you. Dr. Wallace is a native of Tallahassee, Florida. She is a pediatric cardiologist at Sibley Heart Center, an assistant professor of pediatrics at the Emory School of Medicine in Atlanta, Georgia. It's hard for me. Dr. Wallace is a proud graduate of Georgetown University and the Morehouse School of Medicine. She completed residency at Children's National Medical Center and fellowship at Duke University Medical Center. Her clinical interests include the management of patients with dyslipidemia or cholesterol problems, and prenatal management of congenital heart disease, as well as general care of patients with congenital heart disease from birth to adolescence. She is the Assistant Program Director for Sibley Heart Center Cardiology's Preventive Cardiology Program and the Chair of the Emory Department of Pediatrics Pediatric Institute Diversity and Inclusion Committee. In addition to her faculty duties at Emory,
tomorrow, Mom.
and we just ask our audience please to remain muted. In addition to her faculty duties from Emory,
You're muted, Michonne.
hello? Can you hear me? So nobody heard all of my wonderful
we
talk
can
on
hear you.
Dr. Wallace. Can you hear
Yeah.
now?
We
Yes.
heard some of it.
Heard some of it. Okay.
Yes, we heard you were talking
Yeah,
about my
it's all
faculty duties
about-
for Emory.
Okay.
Yeah.
Thank you. Well, thank you. So I would also say that Dr. Wallace was my senior resident when I was an intern. And so I fall very quickly back into the role of that. And so I will give you, you've seen most of what's on the screen. So I'm going to tell you that Michelle is excellent. She's a pediatric cardiologist, world renowned. She's studied at Georgetown Morehouse Children's and trained at Children's National Medical Center, as well as Duke University. Her clinical interests include dyslipidemia, as well as prenatal management of congenital heart disease. She's a member of Alpha Kappa Alpha Sorority. She likes to travel, she likes to dance, and she's about to start right now. Here we go.
Thank you, Dr. Johnigan. I appreciate the invitation to speak here today. That was a very gracious, introduction. All right, so let me get myself together. All right, if you want to go ahead and advance to the next slide, we're just going to talk today about your heart and your health. So to reiterate some of the facts that were presented by the Sisters of Mu Epsilon, I want you to remember that heart disease and stroke are the cause of 1 in 3 deaths among women each year, more than all cancers combined. And yet only 44% of women recognize that cardiovascular disease is their greatest health threat. But yet only 36% of African-American women know that heart disease is their greatest health risk. Next slide. And 51.9% of high blood pressure deaths, otherwise known as hypertension, are in women. And out of all women, Black females have 57.6%, of Black females have hypertension, more than any other race or ethnicity. Next slide. So ladies, I am happy that you have joined this Heart Health Summit sponsored by my sisters in service of Delta Sigma Theta Sorority Incorporated to take the first step to no longer being a statistic. Next slide. So let's start with some of the basics, which many of my sister doctors will expound upon in their presentations. But what exactly is heart disease? Well, heart disease can refer to any type of problem which affects the heart, from arrhythmias to valve abnormalities to holes in the heart. But most frequently, we are referring to coronary artery disease. The coronary arteries are the blood vessels that feed the heart muscle. And if they are clogged or become narrow for any reason, blood flow to the heart is decreased, placing one at higher risk for angina or a heart attack. So what are the risk factors for heart disease? Well, high blood pressure, high cholesterol, and smoking are top 3. Approximately half of the US population has at least one of these risk factors. Next. Additional risk factors include diabetes, overweight and obesity, unhealthy diet, physical inactivity, or excessive alcohol use. So now let's briefly review some of the ways that you can decrease your risk. Go ahead to the next slide one more time. So first, let's talk about first thing we can do is let's have a healthier diet, right? So we can start by keeping our sodium intake to less than 2 grams per day. We can minimize our intake of processed foods, minimize added sugar intake, and cut the fat and choose healthier protein. We can consider eating more plant-based meals. I know a lot of people are doing meatless Mondays now, right? We can choose chicken and fish over red meat. But if you are a true carnivore, like several members of my family are, you can try choosing leaner red meats, such as select cut or round or loin or sirloin cuts that are lower in fat. We also should consider drinking low-fat milk. Really, beyond childhood, we don't need to drink whole milk anymore. And we should consider cooking with healthier oils, such as canola and olive oil, peanut oil, sesame oil, sunflower oil. But if you are like me and you need a quick and dirty way to make a decision while you're shopping and a way to choose a healthier food product, consider looking for foods that contain or that have the American Heart Association certification label on it, as we see on the right. Certified foods have limits on the amount of saturated fat that they contain, the amount of trans fat that they contain, and cholesterol that they can contain. There's also limits on sodium, and they have to have at least a minimum of 10% of the daily value of either vitamin A, C, iron, calcium, protein, or dietary fiber. So this can be a quick and easy way while you're shopping to pick up something that is healthier. Next slide. We should also focus on eating appropriate portion sizes. I'm a fan of the My Plate graphic, like you see on the screen, by the USDA. And the graphic reminds you of the appropriate portion sizes for various food groups. Further, if you go to their website, you can develop a personalized food plan. So you can enter your age, your gender, your weight, your height, whether you're pregnant or breastfeeding, and it will tell you, and based on your the recommended calorie intake, it'll tell you how many cups of fruits, vegetables, or dairy that you should have, and give you concrete examples of how to have appropriate portions of each. And it goes without saying that smoking is not good for you. Smoking can raise your triglyceride levels, it can lower your good cholesterol, it can increase your likelihood of developing clots, damage the lining of your blood vessels, and allow for buildup of plaques in the coronary arteries, which can place one at risk for having a heart attack. So even if you aren't a primary smoker, breathing secondhand smoke can also increase your risk for heart disease by 25 to 30%. So just stay away from it. Go back one more slide. Another way to reduce your risk is to move more. It's recommended that we get at least 150 minutes of moderate physical activity or 75 minutes of vigorous physical activity, or an equal combination of both each week. However, before you start any program for exercise, I always recommend that you speak with your physician to make sure that you are doing activities that are safe based on your personal medical history. Next slide. Last but not least, it's important to know your numbers. Talk to your doctor about your cholesterol levels, your blood pressure levels, your blood sugar levels, and what you can do to improve them. If you have diabetes, talk to your doctor about your hemoglobin A1C level, which is a marker of how well your blood sugar has been controlled over the past 2 to 3 months. Knowing these numbers can be very important in reducing your risk for heart disease. Next slide. So let's switch gears. As the Sisters of Mu Epsilon mentioned, only 58% of African-American women are aware of the signs and symptoms of a heart attack. So let's again fight that statistic today. So what are the signs and symptoms of a heart attack? Well, traditionally, we think about the sensation of an elephant sitting on one's chest with pain radiating or moving down the arm. However, women may present with some atypical signs and symptoms, such as pain or discomfort in one or both arms, in their back, their neck, their jaw, or their stomach. They may feel short of breath, or they may break out in a cold sweat with nausea and lightheadedness. So let's watch a short video illustrating this.
It started out like a totally normal day. Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb estar. What are you doing down there? Did you finish your breakfast? Ow. Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
Oh, you sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, here. You sure? Nobody move. I'm getting a dustpan.
Oh. Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, Tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So as we saw in the video, and I don't know how many of you can relate, but I certainly can. Frequently, we're doing so much, right, to take care of others, right? And we're listening to others about what's going on with their lives and trying to solve problems for others. I think a lot of times we are natural problem solvers, right? We've been resilient. We've done so many things to try to make the world better for our families, for our friends, and others that we sometimes do not listen to our own bodies, right? And if you notice any of these signs and symptoms, please, 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 please seek medical attention. It could be gas, right? But you really don't want to miss a heart attack. And so really, if your body doesn't feel right, seek medical attention immediately and take care of yourself just as much as you take care of others. Next slide. So with these tidbits in mind and regular evaluations by your physician, you'll be well on your way to changing the statistics. So I want to thank you all again for having me to speak today, and I look forward to participating in the panel.
Thank you, Dr. Wallace, for all of that information. And I know that was very well received. I could hear ears pricking up across the country. And I will also just make mention, I did say this before, but I'm gonna say it again. So Michelle was my senior resident when I was an intern, and I used to always love being on call with Michelle because we'd be on overnight, and I knew this girl was unflappable. The stuff was gonna get done. It wasn't gonna be a whole lot of, pity party in the middle of the night. And we had a little presentation snafu this morning, and I talked to Michelle, and next thing I know, Michelle's like, look, we're gonna do this, we're gonna put this slide in, we're gonna do this, we're gonna put in this video, we're gonna do this. And I was like, hey, it was literally going back in time. So I appreciate you, Dr. Wallace, for everything. As we move on with our presentation, we have another survivor story. This is another member of Delta Sigma Theta. This is Miss Bursina Jackson. She is a member of the Conway Alumnae chapter in South Carolina. She is also a heart disease survivor as well as a breast cancer survivor. And she's going to share her story with us, which will lead and transition very nicely into our talk by Dr. Ubani, who's coming up next.
Survival. Continuing to live, particularly under adverse conditions. The endurance of an individual, practice, or principles. Durability, existence, staying alive. The essence of survival isn't tested during the calm, routine, predictable times. Survival is tested in the unpredictable, erratic, uncertain times. Times where you might need a little help from a friend.
My name is Bursina Minchin Jackson. My parents were Brewster and Leila Minchin. I live in Conway, South Carolina. I have one son who I'm so proud of. He completed his doctoral about 3 years ago. I have 2 sisters and 1 brother. My 2 sisters are also Sorors. They pledged long before I did. And my brother's my brother.
Like many women, Miss Jackson's life has been devoted to family, friends, service, and her hobbies. But Miss Jackson's life has not always been calm nor predictable.
I must have was about 28 when I noticed that there was something wrong. I could be sitting down and I get this sensation like all the air was leaving my body. And it would be a split second where I wasn't conscious.
Syncope, or a temporary loss of consciousness, is often not serious. There are instances, however, when syncope reflects serious heart disease.
It may come, I may have one right after the other and not have one again a month, 6 or 7 months. I was on a heart monitor for a week. It never registered.
A Holter monitor, a device that continuously records heart rhythm, can be warmed over a prescribed period of time. Unfortunately, for heart rhythm problems that can be infrequent, like Miss Jackson's, a Holter may not catch the problem.
So I called my girlfriend. I said, you know what? I said, Sarah, I was talking on the phone. I said, and the only thing I remember now is I'm on the floor and I don't know how I got here. So she said, enough of this. So she made an appointment for me to go to the doctor.
The third test prescribed by Miss Jackson's doctor was a tilt table test. Tilt table tests can be used to see if fainting or loss of consciousness is due to abnormal control of heart rate or blood pressure, triggered by a change in a patient's position. Miss Jackson's tilt table test was positive.
What you want first, good news or the bad news? I said, look, Dr. White, just give me some kind of news. He said, the bad news is I can't let you leave the hospital today. And I looked at him. He said, well, the good news, Miss Jackson, is I know what it is. So the next thing I know, they will get me ready to have surgery to insert a pacemaker.
With insertion of her pacemaker, Miss Jackson's heart rate is now regulated, and the blood flow to her body is better controlled. This prevents her episodes of loss of consciousness.
I feel just like I'm 16. I mean, I don't have much as a flitter with my heart. Not even fast beating, heart racing, anything. So I just don't sit around like I was doing. And I wasn't feeling sorry for myself. I just didn't do what I was supposed to do for a better me. The doctors can't do it all. There's nothing to be scared of. The scary part is not knowing. Not knowing. And if your doctor is giving you medication and you're still having the symptoms, I think you need to step out and find another doctor. Talk with people. You may be experiencing something that Sarah sitting right next to you is having the same problem, but won't verbalize it. So talk about things. It's okay for you to have heart palpitations. I'm able to tell you, this doctor is good for that because I was having the same thing too. Communicate. We need to communicate. Having health problems is not a sin. It's not. The sin is not doing anything about it.
Miss Jackson's story may not have been had it not been for the devotion, the loyalty, the commitment, energy, affection, dedication, fidelity, and love of her friend Sarah Margaret Alston.
She was Sister Tagalong. We grew up together from 1st through 12th through 4 years of college. And she knew me apparently better than I knew myself. And she said she just had enough of it. Because she would be me sometimes and she could kind of tell when something was going on because she would always hit me. She said, you okay? And I come back. I said, yeah.
Miss Jackson is a survivor, overcoming both breast cancer and heart disease. Her friend Sarah Margaret has since passed on. But if Miss Jackson could tell her friend one last thing, it would be,
thank you for saving my life. Thank you for saving my life.
So we appreciate and we thank Sorority Jackson for sharing her story with us. I think one of the things that this story illustrates is just how infrequent sometimes cardiac disease can be, and also how confounding sometimes that can be in terms of getting your diagnosis. And we saw that also with Ms. Jordan's presentation, kind of having to go back and get more and more and more tests done. And I think this leads very nicely into what our next presenter will be presenting with us. So it is my pleasure to introduce to you Dr. Jacqueline Ubani. Jackie is a board certified cardiologist and electrophysiologist who's currently practicing medicine out of Orange County, California. She attended the University of California, Riverside for undergraduate and Boston University for medical school. She joined the United States Navy after medical school and completed most of her medical training in the US Navy. While working as a physician in the US Navy, her clinic was responsible for the health care of active duty military, including wounded war veterans, returning from Iraq and Afghanistan, and members of Congress. She served in the United States Navy for 12 years. She's an active member in other distinguished societies and several advisory boards. She has been invited to be the guest speaker for several heart health events because she has a major interest in women's health. Jackie's been featured on the doctor's program that many of you have seen, I think on ABC, and she's also written a book specifically on women's heart health. Dr. Ubani is also a member of Alpha Kappa Alpha Sorority. Her interests include scuba diving, horseback riding, and reading about world history. Please welcome the radiant, enterprising, and passionate Dr. Jacqueline Ubani.
Oh, thank you for having me. That was so kind. That was very nice. Anyway, good morning, everyone. Maybe it's afternoon over there, but in California, it's still morning. Good morning. Thank you for inviting me to speak about this. I'm always so excited to educate women about heart disease because we all know that it is the #1 killer of women here in the United States. So today I was asked to speak about pacemakers. So here we go. Next slide, please. So what is a pacemaker? So a pacemaker is a device that's inserted into the body that is used to control heartbeats. So it's more specifically for people with very slow heartbeats. So normal heartbeat is anywhere from 60 to 100 beats a minute. So what is a heartbeat? A heartbeat is a electrical impulse that the heart fires off in order to generate enough energy to pump blood to the rest of the organs. So it's feeding the rest of the organs with the oxygen and the nutrients that your whole body needs to function normally. Next slide, please. So what kind of signs, symptoms can you have that means you need a pacemaker? Just like Mrs. Jackson, reported, she was having these infrequent but fainting spells. So people with slow heartbeats or very prolonged periods where their heart is not beating at all can have episodes where they feel lightheaded, they're fainting a lot, generalized weakness despite getting plenty of sleep. Like Mrs. Jackson alluded to, she didn't have the energy to do some of the activities that she really liked doing. That's a big sign for patients who need pacemakers. So in general, just lightheadedness, dizziness, just not feeling right. Next slide. So how is it diagnosed? It can be diagnosed by getting an ECG, going to see your doctor. They do this EKG and they can see what your heart rhythm is. But like we learned again from Mrs. Jackson, these episodes don't happen all the time and they can be infrequent. And when that happens, you may not be able to make the diagnosis with just one EKG. You might need to be monitored for prolonged periods of time to catch them. So we have 3 ways that we can monitor patients. You can do the Holter monitor, which we saw a picture of that. It's a way of monitoring the heart rhythm, and you can wear this for 24 to 48 hours. Again, if you don't have any symptoms within that period, you can monitor patients for longer periods of time with a cardiac event monitor, which you can wear for 2 to 4 weeks. And lastly, an implantable loop recorder. It's a tiny little device that gets injected underneath the skin and can remain in place for 3 years because that's how long the battery lasts. Next slide, please. So this is what the typical pacemaker looks like. It consists of a battery and 2 leads. Sometimes you can just get one, sometimes you get 2. It's left up to the discretion of your doctor to decide which one is best for you. So the procedure is pretty simple. It's considered a minor procedure. It's not like major surgery. It can take anywhere from 1 to 2 hours to do the procedure. And most of the time people go home unless there's a complication. You may have to spend 1 night in the hospital. So the way the procedure is done is there's an incision made on the left side. We most of the time do it on the left side because people are right-handed. But if you're one of the few people who's left-handed, then it's usually placed on the right side. So a small incision is made just below the collarbone, and a pocket is made, and the battery, as you can see, there's inserted inside underneath the skin, and there's a vein right in that area where you access, and you can slide 1 or 2 leads into the heart. So what the pacemaker does, it just sits there and monitors you, and if your heartbeat is slow, it helps, regulate the heartbeat and gives you, the impulse, helps the heart with the impulse and the electrical energy that it needs to pump. Next slide, please. So what kind of quality of life will you have with the pacemaker? Basically, you can go back to doing your absolutely normal activity once it's healed. Of course, they'll give you instructions on how to keep the site clean immediately after the procedure. But after that, you can pretty much go on to do whatever you normally do. There are a few things that you just have to be conscious of just keeping away from the pacemaker, because again, it's a mechanical device. So if you have cell phones, recommend, carrying your cell phone, on the other side of the device. Don't keep it too close to the device. You want to stay at least a few inches away from things like chainsaw, power drills, lawn mowers, but you can safely be around microwaves. That's always the question that patients want to ask is, can I use my microwave? Absolutely, you can be close to microwaves. You can use your electric toothbrush, dryers, blenders, all that is no problem. You can continue to travel like you do. You just have to let the TSA personnel know that you have a pacemaker in place, so they can wand you, because the metal detector will go off and it would be very embarrassing. And also make sure you carry your card, your pacemaker card, to prove to them that that really is a pacemaker, so that you don't get in trouble with the law. And these days, most pacemakers are MRI compatible, so you are able to get an MRI with a pacemaker. So in case some other doctor that you're seeing for some other condition requires a pacemaker, requires an MRI, a pacemaker is not a contraindication to getting an MRI. Next slide, please. So how long does it last? The battery can last anywhere from 8 to 10 years, sometimes even 12 years, depending on how often you use it. Because some people may not require pacing 100% of the time. They require 1%, 2%. So if you're not using it too often, then it can last for the whole duration, up to 12 years. So when you get a pacemaker, you're usually sent home with a home monitor. This is about the size of a cell phone. And what you do is you plug it in at your bedside, and anytime you walk by it, they both talk to each other. The pacemaker transmits all this information to this remote monitor, and this remote monitor transmits it to your doctor's office. So you're constantly being monitored. So monitored for things like if the pacemaker starts failing, the battery starts to go down or whatever. So the doctor is really well aware of you, the way the pacer is functioning and all those kinds of things. But you still sometimes need to do in-office, in-person follow-up. And we say about once or twice a year, you need to do in-person follow-up for your pacer. So when the battery does die, you need that battery changed. And the procedure for the battery change is not as big. It's even more, a minor procedure than the initial implant itself. So it's just an incision. You take the battery out, disconnect it, reconnect it, put it back in, and suture it up. It takes all of 45 minutes, and you go home after that. Next slide, please. So what's new in the world of pacemakers? So this is the newest pacemaker that's out now. It's called a transcatheter pacemaker. It's really small, and it actually gets injected through the groin into the heart. And it's very simple, easy procedure. But you should ask your doctor whether or not you are a candidate for this pacemaker, because not everybody is a candidate for this. Next slide. So in conclusion, pacemaker is indicated for people with slow heartbeats. The symptoms that require pacemaker implantation include things like fainting, lightheadedness, fatigue. After a pacemaker implant, your quality of life should remain the same as it was, and you actually end up having more energy and you can do more things. You should make sure you continue with your follow-up plan with your doctor when you have a pacemaker. And remember that there are newer technologies. You can always ask your doctor about it and see if you are a candidate for it. Thank you.
And thank you, Dr. Ubani, for that presentation. And I want to thank you. Jackie is someone to me is so inspirational, because if I would use one word to describe this person, it would be energy. I mean, Jackie is all over the place. She's visited 50 countries. She's written a book. Every time I turn around, she's doing something. And it's just great to see her. And I want to just thank her for coming. And also thank her. She was definitely a source of support for me when I was going through my own kind of health issues during fellowship. So I certainly appreciate you being here. And I certainly looking forward to the discussion we're going to have on the panel coming up in just a little bit.
So good to see you.
And yes, it is afternoon here, just by the way. Next on our list, and another group that I'm super excited to hear from, because we're looking at heart disease not just from the clinical and not just from the individual, but we're looking at health and heart health as a structural matter. I think that it's important for us, everyone in this audience, to recognize that while we do have individual goals for our heart health, we also have to recognize that we live in a larger community. We live within a state and within a country, within a world that's struggling with heart disease. And the American Heart Association recognizes that and actually has an advocacy team that's tackling some of these issues that we can't tackle on our own. Our two presenters today are both members of the Kentucky State Advocacy Team of the American Heart Association. Shannon Smith is the Kentucky State Director of Government Relations and the Regional Government Relations Director in Ohio and Michigan for the American Heart Association. With over 15 years of experience lobbying, Shannon has spent her career navigating the legislative process at the federal, state, and local levels. Shannon is responsible for promoting the AHA legislative agenda across Kentucky while recruiting and coordinating with AHA volunteers. And Ms. Melissa Brown is also joining us. Melissa Brown is a grassroots manager lead for the American Heart Association's Midwest region. We could say the mighty Midwest of the AHA that covers Kentucky, Ohio, Indiana, Michigan, Illinois, and Wisconsin. Melissa has more than 22 years experience in helping advance heart health policy through engagement of volunteer advocates and outreach to decision makers at the local, state, and federal levels. I'm so excited that Ms. Smith and Ms. Brown are joining us, but just to get a feel for what we're going to be discussing and kind of where the American Heart Association sits on this, I think this will be an interesting video for us to watch.
How long will you target me? I mean, most of your friends have been banned, yet you still seek minorities. I don't get it. Menthol, how is it that you only allow the flavors not associated with black lives to be taken? I mean, am I paranoid, or is this a divisive plan to take out the black community? Anyways, I applaud your ability to market my people at a time when my people weren't considered marketable. But at what cost? Your strategy seems to be counterproductive. Although you gave money to community groups and political causes, your infiltration methods have also produced more black coffins. How many of the black youth are forced to see what's left of their parents' carcass? Yes, it is a choice to smoke you. But at what point does a choice become predetermination? You have pumped my community with advertisement and flavors, advertisement and flavors, advertisement and flavors. Your aggressive campaigning has led to generation on generation of learned behavior. Your targeting systems have locked solely onto my father, my mother, my sister, my brother, me. Can't you see the ever in your ways, but is it ever when it's done intentionally? In 1953, 5% of blacks who smoke consumed you. Triple that. 1968, 14% consumed you. Triple that. 1976, 42% consumed you. Now in the 2000s, 80% of blacks who smoke abuse you. Our death rates rise with your profits. And there is too much money to be made to stop it. Why should I hope to see change? You have created for us a new form of change. Bondage, limited choices, a predetermined health condition, a cage. Your actions are Judas. You befriended me to infiltrate my core disguised as feel good and relief. I finally stepped out of cause and seen the effects of how abusive you really are. I'm glad that I let you know about yourself. Because if we were really cool, you would let me go. But we're not. So, how long will you target me?
So without further ado, we would like to present to you both Ms. Shannon Smith and Ms. Melissa Brown. We thank you so much for taking time out of your Saturday to share with us. And if you just don't mind just giving us a little bit of background, and I will on where we're going with legislation, and tell me when to advance your slides.
Hi, thank you so much for having me. I truly appreciate this. Is such an honor to get to present to such an amazing group of women and just passionate individuals about heart health, and appreciate the ability to share the American Heart Association's legislation. And I'm going to take 1 second to hug my daughter goodbye. She is leaving. She is headed out on a birthday trip. So I apologize. I thought that it was going to be right before. So my apologies for that. But I would love to share some about our agenda. And if I could go back for just a moment to that video and how incredibly powerful that message is, because you can see it in his face, you can feel it in what he's talking about. And the tobacco industry, they have been brilliant in their marketing strategies. They have not only targeted minority groups, but they have targeted our children recently with vaping in a way that is so egregious. I mean, my reaction to it is literally a visceral reaction to their marketing tactics, because they market it as candy, as a flavor, as fun. They show it as entertaining, as something that friends do. This is a good idea. They make it feel like you are a part of something if you consume this product, which is why one of our biggest agenda items this legislative session is to nix the next generation of tobacco, of nicotine addiction. And that's what our campaign, that's what we have reframed the way we are messaging this. It's all about youth. And let me back up just a little bit. How are we going to do that, right? Why is this different than what any other campaign is doing across the nation? Why? And crazy, right? In Kentucky, and agriculture, they pride themselves on being tobacco state and agriculture. How will we do this? Well, the biggest problem that one of the biggest problems, and I will outline four, one of the biggest problems that we face in Kentucky is we have preemption laws. And those laws prevent any local community or city from passing a law that is more strict than the state law. So whatever the state sets as the floor for that law, communities don't have an option. In 1996, and I may be jumping around on slides, so if I tell you to pass one, that's fine. But what I really want to target with this is in 1996, big tobacco went across the nation, passing these laws in states, prohibiting local communities from being able to take action at the local level. Why did they do that? Again, brilliant on their behalf because they could look at 50 states instead of thousands of communities passing and addressing any kind of tobacco or tobacco product law. You can go ahead. Well, and what I'll say to this is why we're doing this is this, if we repeal this law or strike this law from the books, it would allow communities to prevent a new generation from becoming addicted just by limiting the marketing, sales, and distribution. We could get it out from in front of our kids, stop the marketing at the local level, the convenience stores that kids stop at on their way to, you know, whether they're getting a donut or a banana. We hope it's a banana and an apple, but it's probably maybe not the healthiest option. But what we don't want them doing is seeing these products when they are checking out with whatever they are purchasing, whether it's gas that they go in to get, they're right in front of them. The ads are on the windows of the stores. You can go ahead to the next slide. More than 1 in 4 Kentucky high schoolers use e-cigarettes. I mean, just stop and think about that for 1 minute. Any of you that have kids or nieces or nephews, even friends, neighbors, think about how many you know. 1 in 4 of them are using these products. And those are only the ones that we know about. I mean, personally, not AHA's position because it's not backed up by science and data. I think it's more. I have 2 young girls and I see the kids that are using, and it breaks my heart. My 12-year-old got off the school bus, 12, okay? So we're talking maybe 10 to 13 on her school bus. Gets off the school bus, she's walking to the car, 2 children in front of her, smaller than her, so younger. One of them brings out a vape and is vaping walking down the street on her way home. Mind-boggling. Kentucky's rates of tobacco use are among the highest in the nation. And Kentucky high schoolers report using any tobacco product at almost 30%. It's the highest rate in the nation. We have got to address what is happening with our youth and vape use, and just tobacco use. You know, we'll back up to 10 years ago, we'd almost eradicated combustible cigarette smoke, like your traditional cigarette smoking, among middle school kids. Okay, we might have still had some in high school. Middle school kids did not smoke cigarettes 10 years ago. Middle school kids are using vapes at an alarming rate. Okay, you can go ahead and move to the next slide. So I've combined a few slides here. I'm going to jump to the middle point here, how to restore local control. The law that is currently on the books at the state level is KRS 438-300. This is the law that has tied the hands of local officials for more than 25 years. And this is a misconception when we talk about wanting to repeal this law. A lot of lawmakers are saying, oh, well, this is a mandate on communities to pass smoke-free laws or marketing laws, or they're going to do away with. That's not the case. What this does, it removes the law and it gives tools to the community to use if they choose. It is not a mandate. They do not have to pass a law. But what we are seeing across Kentucky, and especially rural Kentucky, they want to take action. They want to have the tools in their toolbox to be able to address the needs of their community. And these are the people that they see every day at church, at daycare drop-off, when they're at the grocery store, the dry cleaner, wherever they are daily, the gym, they are seeing these people. So they're held accountable. These lawmakers are held more accountable than our state lawmakers are, and they want to take action. We need to give them the ability to pass these laws if they choose. Okay, you can go to the next slide. Oh, okay, I think I had it in an earlier slide. Before I jump into stroke systems of care and heart systems of care, I will just leave you with this thought. Would you go to well, it doesn't matter. I don't remember the exact number of the marketing that lobbyists.
Let me see. I
think it was an earlier slide.
Okay.
I think it was maybe one more slide
the
back.
First?
Yeah,
first slide
right there
here?
at the bottom. Tobacco, okay, $788,000 big tobacco spent lobbying in Kentucky. That is just Kentucky. And we had this bill before the legislative session last year. It never made it out of the Rules Committee, which means the bill got introduced by the sponsor and it went to the Rules Committee to then be referred to the committee that it was germane to. Never made it. And you know why? Because of that $788,000, they told leadership, if you post this for a committee hearing, we will withdraw our campaign dollars. And there it stopped and it died. We have spent the interim, so since last April through the summer and the fall, reframing our message, our strategy, those that we are empowering, our champions for this campaign, and then our lawmaker champions to make this as apparent to as many people as we can. This is why I'm so excited to present to this group too, because I feel like your voice can bring another group to the table to challenge our lawmakers to hear this. And what I will say, as of Friday, this could not be more timely. Our sponsor is Senator Will Schroeder, and he filed the legislation on Monday. We have been posted for a committee hearing in Health and Welfare this coming Wednesday. At the end of my slides, there will be an action alert. I would encourage you to please take action. You can go to the end and and if anybody wants to take action now, they're welcome to. This is it. You can text Nix the Next to 46839 and you can share that with anyone you know. And that will send a message to lawmakers telling them you support this. Give our communities the ability to nix the next generation of nicotine addiction and keeping our children, and not just children to young adults into adulthood. And we all know, I'm not going to get on the platform of what it causes and the health devastation that it has on all of us with, from the economy to personal health, right? It is kind of the one thing that is a choice that we could stop if we could stop that generation. So I know I'm jumping around. I should have planned this out a little bit better. So my apologies. I will.
It's all right. Well, that's what sisterhood's all about.
Thank you. And I'll stop with Nix the Next. But as you can see, I'm incredibly passionate about this campaign and just hope that we can do our part to give communities the power to help. Okay, next huge piece of legislation. There's two, and lots moving with this. I'm also excited for this group because I think you guys are going to be extra excited about these two pieces of legislation. When I talk about these, I am not clinical, as you all are clinical. It is hard for me sometimes to talk about the difference in a comprehensive heart attack center versus an acute heart attack center. But I'm pretty sure you all are very aware of the differences in those types of facilities, as well as stroke. So in Kentucky, we have a wonderful stroke systems of care. We also have a registry. So those hospitals are designated stroke hospitals. They have gone through accreditation, and we know whether those are comprehensive, primary, or acute. Senate Bill 55, the Joint Commission has come out with new research identifying a new level of stroke certification, thrombectomy capable centers. So we have included as the third level, so the highest being comprehensive, next thrombectomy capable, then primary, and then acute. So this bill has passed the Senate unanimously, awaiting action in the House. We do hope that there will be action taken in the next couple of weeks, and we anticipate this bill being sent to the governor's office very soon. So great things for our stroke systems of care. Heart hospital designation. Couple of things about this one. And am I doing okay on time? Am I going over?
Yeah, I think we can finish this slide because we had a couple of questions that were submitted.
Okay, so this bill, unlike stroke, so stroke has stroke hospital designation, also has a registry. With the hospital designation, we removed the registry component because of the COVID crisis and our shortage of clinical staff. We know that those that are participating and inputting data in the registry have to be clinical staff. It can't just be someone that doesn't know what the procedure was or what the patient was going through. So our being sensitive to hospitals and hospitals' needs, we removed that component. This bill will allow the systems to talk to each other. The cabinet will designate heart hospitals as comprehensive, primary, and acute, and recognize that accreditation so that EMS know the treatment transfer protocols as it relates to where patients need to go and what, time is muscle. Where is the best place for that patient during a heart attack or cardiac arrest? So I can pause if there are questions.
Shannon, if you don't mind, I want to just add a little bit of the clinical piece here. And people should understand the American Heart Association and the American Stroke Association are actually the same organization. And the reason for that is both heart attacks and stroke are results of atherosclerosis. So atherosclerosis is, as you know, is the buildup of plaque in blood vessels. When you have a development of plaque in the blood vessels of your coronary system, if that occludes those coronaries, then the heart muscle downstream becomes ischemic and then necrotic. Same thing in the brain. If atherosclerosis develops in the cerebral arteries, then if it occludes those arteries, then the brain tissue downstream becomes ischemic and necrotic. Why am I making that particular point? Is that when we talk about time being muscle, when a muscle tissue or brain tissue is ischemic, it still can be reversed. That damage can be reversible. Once tissue becomes necrotic, it's no longer reversible. So in both atherosclerosis of the heart and the brain, it becomes very important to make sure people have care timely. So when we're talking about the stroke system of care, we're talking about heart hospital designation. We are literally talking about how far away are you from your tertiary level of care. And so one of the things we're concerned about in Kentucky is that we know that the American Heart Association guidelines actually speak that say that you should have care within 90 minutes of your first medical contact for a heart attack. In this state, do we have the capability to make sure that all of our citizens are within 90 minutes of a heart attack center or within a certain driving distance of a stroke center? Because the distance you are to the hospital can make the difference in your outcomes. I just want to add that part to it. I'm sorry, Shannon, was there anything else that you wanted to add on that?
No, do I have another slide? Thank you for that. This is why I love this group. I want to be involved all the time because I love this kind of conversation, and the presenters before, this is just wonderful. So this is just data on the outcomes of once in 2008, there were 6 certified stroke centers in Kentucky. Since stroke center designation legislation was passed in 2010, it has grown to 41 centers. I don't need to read these bullet points necessarily. The overall point I wanted to make with this slide, patients are getting better care because of stroke systems of care. They're going home to their families, they're living longer, and hospitals are actually doing financially better when accredited and have these systems in place, because there is a system in place. They do know exactly what to do from the moment that person checks in the door. What do they need to do to make sure that they have the best quality? So that is the reason why we are pushing for the heart systems of care also. And I would like to add here, I understand in the last few days with conversations, the Kentucky Hospital Association is potentially going to oppose this legislation. They believe that because Kentucky has a certificate of need process that it covers, and we don't need accreditation designation at the state level. I would disagree, because what CON covers is how quickly they get, and I'm going to say this, feel free to laugh at me, anyone stop if I don't say it exactly right. If that hospital is PCI capable, when they receive that, that's where that standard of care stops with CON. If you have accreditation, it follows the patient from check-in to rehab. It is the entire system, the entire process that it takes to care for a heart patient. I think the next slide articulates that a little better.
Okay,
No, it doesn't.
so So Shannon, we are going to, I think what we were discussing just prior to getting prepared for this event is since we have this kind of marriage between, you know, our healthy living and our social action, is that I think it would be good if we could get together and have just a full session just on this legislation. I was hoping this could be kind of the beginning, and I think we're off to a great start in terms of understanding, because I think a lot of people don't necessarily understand that there's legislation in our Kentucky state legislature helping our health. So would you, possibly, and Melissa, we can touch base maybe a little bit offline and think about let's having maybe another conversation in the future?
I would love that. And anytime you say Saturday, Sunday, evening, I don't care. I mean, you tell me when, I'm there. I would love to do that.
All right. Well, we will certainly do that, and we appreciate both you, and I know Melissa has been putting information into our chat. We appreciate both of you for introducing this legislation to us, and we will get this, I think, most importantly here on your last slide, we'll get this information out to the community and make sure that we really understand exactly what the next legislation, how it's targeting our community and our children.
Thank you. I can't say enough wonderful things about that. The last one I will just tell you really quickly was the postpartum extension. There was one slide there at the end. The legislation passed, this legislation passed the House on Friday, and this extends Medicaid coverage postpartum from 60 days to 12 months. If you take action that says text KY moms to that number, we are asking for them to support the legislation, but also to support the funding needed in Medicaid to support the 12 months of coverage. It's crucial that, you know, healthy mom, healthy baby. And we know that the postpartum death rates of baby and mom, they're far past 60 days. So it's also critical that we make sure that this legislation, House Bill 174, gets passed and is included in funding. You will hear more from me on that one too as it develops. So I can hush there. Sorry. I know I have a lot and I'm super passionate about it. So I probably should have warned you up front that I'm chatty.
Well, I knew that. So that is good, because that's exactly why you are gifted to be in the position that you're in, because you do have that loquaciousness that comes in quite handy. But we appreciate both you, Shannon, and Melissa, for joining us, and we will continue this conversation definitely, because we recognize one thing we don't want to do is have a session today and we get all this information and we don't take it out to the community that needs it. So we will make plans to continue this conversation, both with you, and continue our own advocacy in our community as well. All right. At this time, we're going to move into our panel discussion. We have some excellent panelists that are going to be joining us. We'll start first with Dr. Rochelle Brown. Dr. Rochelle Brown is a native Lexingtonian. She recently returned to Kentucky to be closer to her family. She currently works as medical director for United Healthcare and practices telemedicine. Dr. Brown got her Bachelor's of Arts from Northwestern University. She attended medical school at University of Kentucky, completed a residency at George W., or GW, as we know, at University in Washington, D.C. She has worked as an academic physician at GW University and completed a fellowship training at New York University, earning a Master's of Science in Clinical Investigation with a concentration in public health. She's continued her academic endeavors at Johns Hopkins University, where she served as a clinician, educator, and researcher. Dr. Brown's interests include cultural competency, health disparities, and obesity. She is a proud member of Delta Sigma Theta Sorority Incorporated, Lexington, Kentucky Alumnae chapter, and she enjoys in her free time time, which she does not have much of, I can say, barre running, cycling, and entertaining. Also on our panel, joining us, I'm very proud to introduce, present to some and introduce to others, Dr. Tamara Bynum. And so Dr. Bynum is a native of Charlotte, Tennessee. She is a biomedical engineer with a specific emphasis in medical device R&D consulting. She is the founder of Ingenuity Medical Device Research. Dr. Bynum's passion and her clinical interest, not just in biomedical devices, but cardiac devices, in particular, cardiac pacing and modulation. Dr. Bynum is a graduate of Vanderbilt University, and she holds master's and doctoral degrees in biomedical engineering from the University of Alabama at Birmingham. She's worked at Johnson & Johnson, Boston Scientific, and she has over 40 patents granted by the United States Patent and Trade Organization. Dr. Bynum is a proud member of Delta Sigma Theta Sorority, Nashville, Tennessee Alumnae chapter, and in her free time, she enjoys biking, karaoke, and reading. And last but certainly not least, we are welcoming our dear friend, Ms. Laureline Jordan. We've already heard Laureline's story as part of her video. She serves as senior recruiter for Accenture Incorporated. She holds a Bachelor of Science in Political Studies in Illinois State and a Master of Political Studies in Public Policy from the University of Illinois Springfield. And she's a member of Delta Sigma Theta Sorority Incorporated, Minneapolis St. Paul Alumni Chapter. And if you cannot tell, I did this in part because Michelle and Jackie were outnumbering me with the whole Divine Nine thing. So I weighted things a little bit in my favor. So please welcome all of these devastated divas to our panel. And I think I can probably stop screen share now and have us, if we can get us all on the screen. All right. Welcome, welcome, welcome. So our panel discussion we have today is we are actually going over some pre-submitted questions because we had quite a bit of interest going into this. And so we're going to kind of start actually with Sora Jordan. And I'll just make sure we're not in sorority meeting. So Ms. Jordan, so would you mind, one of the conversation pieces that we had during our discussion was talking about exercise. And I know that you're a big exercise enthusiast, and that actually kind of led you into recognizing you're having problems with your heart. So why don't you just tell us, and particularly for those folks who maybe aren't as exercise inclined, how exercise really helps you know your body?
Definitely. For me, it was key because I was an avid, exerciser, biking, walking, doing 5Ks. I can be on a treadmill and I would hold on to the heart rate, and it definitely let me know something was going on because, I would check it very, often, and I could see the changes. Like I would go from 110 to all of a sudden I'm at 155 or 160, 170. And I'm like, oh, that's high. That's something's not right there. I'm an avid, I have my Fitbit. I'm super competitive. So now tracking that and watching that tells me, okay, yeah, let me go get this checked out. Oh, something's wrong here. And it was because I've tracked that all along that let me know something was going on. So and then having that regular exercise, it kind of helped with my rehab because I was so used to walking. When I did go into cardiac rehab, it kind of kept me motivated to continue to get back up to where I was. I remember speaking to Sora, telling her that my mom would lap me on the track, and it was very frustrating for me because I would lap them any day, anyhow, and now they're lapping me, and I just had to get back to being able to walk faster than my parents. They can't lap me on the track.
This is true. This is true. There's some generational something about that should just not happen. But Ms. Jordan does bring up an extreme point, and I was wondering, Dr. Bynum, if you could touch on that, because obviously we'll talk about smartwatches and Fitbits are, they're part of our culture now, and a lot of people rely on them. But just how heavily should we rely on, say, smart devices when it comes to measuring heart rate and blood pressure?
Yes, so specifically with Fitbit and the Apple Watch, they have actually done the clinical work to get FDA approval for their method of determining heart rate and actually detecting atrial fibrillation, which is the clinicians can elaborate on what atrial fibrillation is. So for instance, with my Apple Watch, I can go to the app and just touch my knob here, and basically what I'm getting is a single lead EKG. And so that single lead EKG has been studied in clinical trials and shown to be equivalent to what you can get with an in-hospital EKG recording and the detection algorithm associated with it. So you can absolutely depend on the Fitbit and the Apple Watch for being able to detect whether you have a heart rhythm issue. One of the things that Apple Watch does specifically is when you have a high heart rate that actually happens too fast or happens when you're just sitting there, you will get an alert that you have a high heart rate. So that's something that you can take to your doctor that can help them to talk a bit about what is going on with you, as well as the blood pressure monitors that you see in the stores. They are also FDA approved, but you have to use them correctly. They're a little trickier than using a Fitbit. So you have to actually have your arm positioned correctly, and the cardiologist will tell you about how to do that for those to actually be accurate.
As you're speaking, Dr. Bynum, I can just feel like Jackie jumping over my shoulder somewhere. So, Dr. Ubani, do you want to jump in here and discuss your patients and that you're working with and your experience clinically with using, say, smartwatches and Fitbits? So you're on mute. See, I got you back.
So hi, everybody. So yes, a lot of patients do have these smartwatches these days, and it's actually been helpful in helping diagnose arrhythmias or abnormal heart rhythms, and even managing them, because my patients can, well, I mean, we have monitors that we can give patients, like I talked about earlier, the Holters, the cardiac events, but you can't wear that indefinitely. So the watch, which people are carrying all the time, ends up being a good way for them to monitor their heart, maybe even come up with a diagnosis of an arrhythmia, when then they'll have to go see their doctor, who then gives them the diagnosis of maybe AFib or any other kind of arrhythmias. But as we know, AFib is much more important to make the diagnosis because of your risk for stroke and the need to be put on anticoagulation. So this watch has now brought a lot of people in to see the doctor with arrhythmias that they ordinarily would not have found out if they weren't wearing these watches.
And Dr. Bonnie, could you possibly just, for the audience, just briefly give us a feel for what exactly atrial fibrillation is?
Yeah, so atrial fibrillation is an abnormal heart rhythm in the top chamber or the atrium of the heart. So typically, the way the heart pumps is, blood goes into the top chamber, which is the atrium, and it contracts synchronously to push the blood down into the ventricle. And then the ventricle contracts synchronously to push the blood to the rest of the organ system. But in atrial fibrillation, the top chamber of your heart is not contracting. So it's what we call fibrillating, kind of like a bag of worms. So you have blood kind of static in that chamber. And you guys know that once blood is static in an area for a little bit, it can form blood clots. And, the heart can contract and push that blood clot straight to the brain and cause a stroke. So this is why AFib can be dangerous. And the problem with AFib is some people are asymptomatic and have absolutely no symptoms. So without the watch or without any kind of monitoring, you don't know you have it until you have a stroke. So the people who have symptoms are for lack of a better word, better because they come to medical attention a lot sooner than people who have absolutely no symptoms and end up showing up in the ER with a stroke.
Okay, and Dr. Bynum, I'll pick your brain one more time because, you know, we don't see it, much of any AFib in the pediatric population. But I do know that there have been some studies starting to link more obesity with atrial fibrillation. Is that something that we should be concerned about, or what risk factors have you seen in your population with regards to AFib?
Yeah, there are lots of risk factors associated with atrial fibrillation. Obesity is one of them. What do you call it? If you have thyroid issues, alcohol for sure. Yeah, thyroid issues. If you have alcohol, drinking alcohol for sure. It's funny, we call AFib like the holiday heart. Holiday heart coming into the ER after Christmas, after Christmas holiday or after New Year's because they've been binge drinking before. If you have lung problems, if you have COPD, asthma, these can all predispose you to having atrial fibrillation. And yes, so if you exercise, you lose some weight, you can actually, hypertension, that's also the other big one. So exercising, losing weight can help, decrease your risk for developing atrial fibrillation.
And that kind of leads into kind of an even larger discussion with regards to obesity, because one of the things that we know within our population of women of color is that our figures tend to be on the more curvy side. And so when is curvy too curvy? And so, Dr. Brown, could you talk a little bit on, from your experience, at what point you would start to maybe refer a patient for, say, an obesity referral or bariatric treatment?
Sure. Thank you for laying that one in my hands. When is curvy too curvy?
When is curvy too curvy?
And actually, yeah, that's actually a great question. The standard that we use, the standard measure is BMI, or body mass index. If you don't know your BMI, there are plenty of calculators out there. You can go to Google, and the one I usually use is from the NIH, or it's the NCHBLI, the National Heart, Blood and Lung Institute. And you just put in your height and weight, whether you're male or female, and it'll pop out a number. And this number is compared to the standardized scales, and it'll give you a number, and we put that into different categories, and that determines whether you're considered overweight or underweight, normal, overweight, or obese. Those are the standard characterizations. You'll start hearing words now like super morbid obese and super obesity that are not part of the standard categorization, but they're words that you'll hear in the medical community. So, this is what we have. This is what is determined as to put you into one of those categories. But there is criticism of that categorization because it only takes into account your height, your weight, and your gender. So the example I always give to people is that I would assume that Serena Williams probably by BMI is probably, obese or something like that. I'm just guessing. But we all, I don't think many people would say that she's unhealthy because she's, a supreme athlete. So it does get criticism because it doesn't take into account, there's a person who could be 5'4", 200 pounds, all muscle, and someone who's 5'4", 200 pounds, and they're all fat, more fat. So it's not perfect, but it's what we have. That said, I think that just to step back a little bit, I think that an internist or family medicine doctor, a standard adult medicine physician, can manage obesity. It can manage you through training you on diet, exercise tips. We can, there are medicines, although I don't prescribe them very often. There are medicines that have been used over the years for weight loss. They can, suggest tips for you. They can refer you to a nutritionist. There are a lot of things that can be done at that level. But I think, if someone is significantly overweight, and if they have, which would be considered about 100 pounds over their average weight, which I'm using air quotes under the table, that might be someone who you might refer for for obesity management, namely weight loss surgery, which is, as aggressive as it sounds, it's probably the most successful tool we have for weight loss for people who are significantly overweight. Unfortunately, diet and exercise doesn't work well for everyone, and it's difficult to maintain. I think I won't say every woman, probably the majority of women know how hard it is to lose weight and maintain that. So, we would refer you if you were considering weight loss surgery, but just to know that, insurance companies have very strict rules about who's going to be covered for that. So even if you feel like you need weight loss surgery, your insurance company is likely going to require you to have documentation that you've tried a supervised weight loss management program, like with your physician or Weight Watchers or something, not just, oh yeah, I've tried everything and nothing's worked, now give me a lap band. I mean, that's not quite how it works. So I would say, if you're concerned about your weight, first and foremost, talk to your primary care physician and have that person talk with you about what you've tried, what hasn't worked, maybe give you some suggestions of what could be tried, and then consider referral for other options like nutrition, or there are specializations now in obesity medicine that a lot of physicians are obtaining, which, my bias is that most well-trained internists or family medicine doctors can manage obesity management, at least at the first level.
And I want to kind of take this a little step further, because I know that Michelle and I are kind of chomping at the bit. I'm going to let Dr. Wallace get in here because we see things kind of on the other end of the spectrum. Because the same problems in terms of obesity and hypertension and dyslipidemia that we're seeing in the adult population are now in children. And it's really become almost a generational curse, but everybody doesn't necessarily recognize it. And so I wanted, Dr. Wallace, if you don't mind just giving us a little bit of some background on what are the trends that we're seeing now in terms of childhood obesity and preventive cardiology.
Yeah. Thank you, Dr. Jonathan. So we're seeing more and more that children are becoming obese, right? And it's becoming an epidemic amongst children. And it used to be something that we only thought about for adults, but now we're thinking about this more and more. And actually, as you talk about bariatric clinics that exist, or obesity clinics that exist, we're now seeing those in the pediatric population as well. And for our kids that are, we determine a child's BMI based on their height and their age. Their height and weight and age. So as we are considering children who we're going to refer to these clinics, normally they're greater than the 99th percentile. And the great thing about some of these clinics is that they're very comprehensive. So for instance, at our facility at Children's Healthcare of Atlanta, there's an endocrinologist involved, there's a psychiatrist involved, in addition to an obesity specialist. And frequently our group as pediatric cardiologists, as well as the nephrologist, are very involved in trying to manage a lot of the blood pressure and lipid issues that go along with that. But what we're also seeing very much so is this pandemic has really, so pre-pandemic, children of color had the highest prevalence of obesity, right? So Hispanic and Latino or Latinx and Black African-American children had the highest prevalence of obesity. So this is really something that's very important to our community to think about how we can get our children active and to fight this epidemic, because we know a lot of this tracks into adulthood. And the pandemic has really just made this worse because our children are spending more time on their computers, on their phones, trying to get their education. PE is no longer existent for some of them, or just coming back. And even pre-pandemic, we were losing a lot of our physical education programs. So children may not have as much recess, they may not have as much activity even before the pandemic started. And now this
IT guys were right with us right up until then. So I think it's interesting. We're talking, I'm going to let Dr. Wallace get unfrozen. But I think it's interesting that we're talking about, and she did mention that psychological portion of it, because I don't think you can really talk about most physical health these days without talking about mental health, and how mental health impacts your activity and what you're able to do. And then talking about the pandemic in a nutshell, and how that was trauma to us all, and it continues to be, because it's not over, if you want to talk about that. But Ms. Jordan, okay, you're moving around on the screen. Ms. Jordan, we talked a little bit about, after you had gone through your cardiac bypass and the rehab that you had to go through, and being a survivor. And I will just say, being a breast cancer survivor, there's a whole lot of programs for us. There's really not a lot of programs for people who have survived cardiac disease and really digesting that mental piece. So could you speak a little bit about kind of your mental journey going through life after rehab?
Well, first, it took me a minute to realize I survived. So after you get through that, okay, I survived. And then from there, it was a point of, okay, I need to get back busy. I spent a whole year of just, I did my cardiac rehab. And it was interesting because even at the cardiac rehab, they're like, oh, you had a heart attack. I'm like, no. I had an aneurysm. It's different. Yes, I had the bypass surgery, but it's different. And so just after the cardiac rehab, it took me a minute to actually get back into being active and exercising again. It was just that every little pain or tweak, I was like, is it happening again? It's that whole mental block of, okay, I almost didn't make it. And having that, it took a while to get there, to get back into exercising. I had some good friends that would, come on, go for a walk with me. And then I, had another good friend that was like, okay, I found this great class. And then I was saying, like I said, I'm super competitive. My older sister found this Zumba class. And I'm like, if she can do it, I can do it, because I'm way better health than she is. So if she can do it, I can do it. And, it was a point of, I talked a friend into going with me. And from there, I ended up becoming a Zumba instructor, and then I also became a spin instructor. So that I got back into that whole healthy lifestyle. But it took me a minute mentally to get myself together, because going through that type of traumatic experience, it takes a while. It takes a while to get there. And like I said, it took me about a year to realize I was still going to live. And then it took me about 10 more years before I even started sharing my story, because I didn't know if I would make it day by day.
Well, that part, I think any survivor can attest to, because you do go through that period of, I've made it. Did I really? I'm not sure. And it takes you a while to really understand that you're still here and you still have a purpose. But that being said, I wanted to bring all of our panelists together, because there's one question I asked you, I told you guys I was going to ask. And I think it for every woman that's in this audience, we're all kind of balancing kind of that kind of superwoman, whatever. And our SOAR president mentioned it earlier. So I was going to start with Dr. Bynum, because I purposely wanted you to be here today, just because I just wanted to illustrate your brilliance. But you have to also be balanced, if that's a word. And so, Tamara, do you mind just sharing with us, how do you do it?
One of the things that I do is always trying to make sure that I take time to take care of myself, whether that be and not say things are too expensive for me to do. So I don't necessarily like shopping. So I shop on Instacart, and by shopping on Instacart, that keeps me from picking up stuff that I don't need to be picking up. Yes, it costs more money, but it keeps me from picking up stuff that I shouldn't be picking up in the grocery store.
Gotcha.
And I also make sure that, I also didn't want to pay for that Peloton, but I found that it's the easiest way for me to get exercise, because I don't have to pack up my bag and go somewhere. So just kind of put myself first and not feeling guilty about doing so.
Right. Dr. Bonnie, now, when you are actually in the country, or maybe when you're outside the country, I don't know, but how do you take off the cape when you fly so much, I guess is where I'm going with that. And you're on mute.
Well, I mean, for me, actually enjoy exercising. I enjoy, you know, some kind of aerobic activity, and I go in the morning before I go to work. So I get up early. This is not for everybody, but I do get up early, 4 o'clock in the morning, and go to the gym for about 45 minutes, and then go on to work. And you know, I try to stay engaged in my hobbies. I love to travel, so I have to make time to travel. And do other things. So I just make time in my life to do other things that are distressing, that, you know, helps me just not think about work, not think about medicine for just even a short period of time, use, you know, the other side of my brain to think about things. And those are those kinds of things I make an effort to do them to de-stress.
All right. Dr. Brown, you're the next one. My screen keeps going around and around. So you're the next one we're going to ask that question.
Sure. Like everyone, you know, I try to find things that are relaxing. For me, boundary setting, which I'm a work in progress on that, but especially at work, learning how to say no, which many of us are not good at, I feel, as women. Outsourcing where I can, that also is hard for me because I want to have my hands in everything and I want to do everything, but sometimes sort of on the same vein as Instacart, sometimes paying for someone to clean your house or paying for, you know, help here and there instead of trying to do everything can be helpful. And then I'm always, you know, on YouTube looking at techniques like aura fluffing and things like that, just for relaxation. And sunlight. For me, sunlight is therapeutic. So I try to get outside and just, you know, let the sun hit my face as often as I can.
Dr. Wallace, you're back. We thought you might have run out to Times Square on us. Did you have anything else that you wanted to share with us before we lost you?
No, and my apologies. My internet connection went down, so I apologize for that. In this technology-driven world, something has to happen, right? So no, but just that, you know, we really have to be mindful of the children and what they're doing, and so we can prevent the development of obese adults who then go on to be at higher risk for early heart attack and stroke. So that was going to be my wrap-up sentence, and then I lost connection, but I appreciate you being patient with me. But you were asking about Superwoman syndrome, yes. And how I combat it, and like it was just mentioned by Dr. Brown, I'm a work in progress and all of that. Agree with having to try to find ways to say no, because I like to say yes to everything. But I've also been trying to, especially this pandemic has really forced me to think more about what I do for exercise. And I'm horrible about getting up in the morning and doing exercise. But what I have found for myself is on the weekends, making sure that I get out, and I'm now part of a hiking group. I learned that I like hiking during the pandemic. Who knew? So I get up in the mornings and I go hiking with friends, and it gives me an opportunity to connect with people and to not think about work and to get some fresh air and catch the sunlight. And even if there's no sunlight, catch a little breeze across my face. And that just lets me know that I'm alive. But I think one other thing that I've learned through all of this is that sometimes you just have to rest, right? And, you know, sometimes you're pushing yourself to get everything done, and your body just can't do it. And when you take a nap and you wake up and you're refreshed, you do things a whole lot more efficiently. And so I've been really focusing on trying to get more rest, or at least enough rest. And if my body's telling me we're at our wit's end, then I listen to it, right? We talked about listening to your body earlier. Ms. Jordan spoke a lot about that in her presentation. And so I think that's really important that we listen to our bodies, we get rest where we're needed, because we're our best selves when we're our most rested, and we think clearly, we do things in excellence. And so I've been working a lot more on that.
Thank you, Dr. Wallace. And Ms. Jordan, being a superwoman, how do you take off the cape?
No is a sacred word, and you can say it. And it's kind of like, you know, especially when I think about work, you know, if I go tomorrow, they'll replace me with a contractor the next day. So, I mean, you have to put it in that perspective. Find an exercise buddy. So I have exercise buddies that challenge me. and they go with my crazy ideas. So, and for this winter, for me, it was just like, we're in this pandemic. I wanted to try something new. I convinced my mom to go to Colorado with me so I can learn how to ski. A friend convinced me to go dog sledding. So I learned how to dog sled. I've done a half marathon. It's just finding that exercise buddies that help you do the craziest things that you want to do, to keep moving, to keep active. But going back to no is a sacred word, and know when to limit yourself. Know when to, if you feel like you're in too much, get out of it. You don't have to be chair of everything. You can take a step back and it's okay.
Absolutely. So I was taking a list. So we have Dr. Bynum is saying basically pampering yourself and treating yourself to whatever is making you queen for the day. We have distraction from Dr. Ivani, just to get away from it and kind of lose yourself in yourself. We've got boundaries and outsourcing from Dr. Brown. And so she's going to build herself a little wall, and she's going to get evidently sunlight at the same time within the boundaries. So we'll see how that works. And we've got fresh air and exercise from Dr. Wallace. And we have no as a sacred word from Miss Jordan. And I guess if I was to add anything, which I really can't, exercise would definitely be number one. And then number two, I would also say is that, and this isn't really so much for us as individuals as much as it is for us community, we have to be our own sisters keepers on this and recognize when someone is, performing or acting strangely, we have to, or maybe not quite themselves, we have to be comfortable enough to ask them exactly, do you, can I help you, or is anything going on? We have to figure out how to have that dialogue without making people feel that there's something wrong with saying that there's something wrong. We did have a couple of interesting questions in the chat. If you don't mind just bearing with us another couple of minutes for Dr. Bynum and for Dr. Ubani. I believe we have one specifically for you guys with regards to blood pressure monitoring and EKG monitoring on Cardia mobile. And then also with regards to, so apnea, central, so Dr. Bond, if you don't mind answering the question about central apnea worsening AFib. And then if either one of you want to take a crack at cardio mobile for monitoring of blood pressure and EKGs.
What is the question? Yes, central apnea.
So I think the question is with regards to, is central apnea considered a risk factor for AFib? I think is the question.
It's more obstructive sleep apnea than central apnea, because with obstructive sleep apnea, you're not getting oxygen and you're, when you're sleeping and the heart's struggling, and that can throw you into atrial fibrillation. So it's more obstructive sleep apnea than central apnea. But as far as the cardiac goes, I've actually recommended a couple of patients get that at home again, because sometimes people have arrhythmias. Arrhythmias can be difficult to diagnose because you feel it at home, but every time you go see your doctor, there's nothing going on, and you wear monitors for months and months and still nothing. So on occasion, I'll recommend Cardia that patients can purchase one of these. I think it's $99 or something. And if you feel this, you can put your finger on this and we can see what rhythm you have. And it's actually been helpful sometimes in patients in catching arrhythmias, especially those that happen very infrequently.
Yeah, and for me as a biomedical engineer, I'm totally amped about, I've always been totally amped about Cardio Mobile and the suite of products that they have. So they have actually, have the ability to do the single lead EKG where they can diagnose atrial fibrillation, but they also have the ability to do a 6-lead EKG, which allows them to be able to diagnose other arrhythmias, like if you do have a heart attack, if you look at your, if you have ventricular fibrillation or other arrhythmias where you have fast rhythms, and different things, like Dr. Ubani was saying earlier. If it only happens infrequently, you can do those rhythms, do those recordings, and those recordings actually use detection algorithms that are used for defibrillators that have been transferred to this app that you have on your phone. Also, because they have all this data for millions of people, they're able to use artificial intelligence and machine learning algorithms to actually improve upon that detection in a rolling way. So they're always improving on their detection. And they just came out with a credit card sized Cardia Mobile. That's $149. So the other one is $99. With this thing, you can just put in your front pocket. So they just got FDA approval for that this past week. So that kind of were top of mind for me this week. So Cardia Mobile is FDA approved, and they're doing some fantastic things. So even if you just like to play with it, like I do, it'll be fun to have those at home.
Thank you. And thank you to all of our panelists. We're going to conclude our panel discussion now because Superwomen need to get a nap. And I think all of us have been burning midnight oil this week with everything that we have going on. But we want to thank everyone here for taking the time, and not just our panelists. Attending an event like this is just as important as presenting it, because you're going to take this information out into the greater community. One person can't do it all. So we really appreciate everybody being here today. And I will make one comment, and we can edit this out if need be. If everybody just take a look at the screen, this actually has nothing to do with healthy living per se, but everybody take a look at your screen. Everybody smile. There's no reason a face like this shouldn't be on the Supreme Court. I'm dropping the mic. You all can take that however you want to. I'm handing it back over to SOAR President.
That was a mic drop moment, and I agree. I just want to thank everyone for attendance today. We received some very good nuggets. Remember, we can take our capes off at times to preserve our own health. We need to give ourselves permission to say no. We need to ensure that we take care of ourselves first. We need to exercise. We need to work on our diets. And more importantly, let's make sure that we keep up with our friends and family to make sure that if they are ignoring certain symptoms, that we are our sister's keeper and we are taking note of that. The best story was that there was the friend who did it when she wasn't listening to her body. Her friend took charge. And so we just thank you for being here today. Again, thank all of the panelists for being here. Thank all of the presenters. We thank those who are just here listening. We hope that you take this information back with you to your family, your friends, your community. So again, thank you and good afternoon.